Hi friends, if you're a beginner working in pediatrics and you know that specific feeling of anxiety when you get called to a delivery, especially if it's a preterm baby, you want to help, but when you look at the official manual, it can feel quite overwhelming. So I hope this video can change that. Today we're breaking down the latest NRP 9th edition, which debuts in the 2025. NRP is a gold standard in the neonatal resuscitation. We're going to walk through it step by step and adding in some of my real-world experience to make it stick. But before we look at the steps, you need to lock one most important concept into your brain. In adults, cardiac arrest is usually a heart problem, a pump failure. But in newborns, it is almost always a lung problem. I repeat, it is almost always a lung problem. If the baby is not breathing, then the heart slows down. And therefore, in neonatal resuscitation, most of the steps are actually fixing the lung. If you fix the lung, you fix the heart. Okay, we keep this in mind as we go forward. And by the way, if you're new here, I'm Dr. Oliver. I'm a pediatrician with over 10 years of experience working in general peds, the PICU and the NICU. I created this channel, Paediatric Squad. I hope to build up a community for pediatric healthcare providers like you. I hope to help you ease that steep learning curve, and then you can feel more confident on your next shift. Okay, now let's get to work. Chapter 1. In preparation, here is one thing you need to know. NRP starts before the baby is born. Okay, most people think resuscitation begins when the baby cries or doesn't cry. But the truth is, good preparation can ease your anxiety by 70% before the patient even arrives. And therefore, you need good preparation. And the preparation starts when you get the call. There are 4 specific questions you need to ask. So first, what is the expected gestational age? Be careful here. If they are less than 36 weeks, your setup can change. You need to think of using the Neonatal because it can get CPAP. And below 32 weeks, you need a plastic wrap. And more importantly, if the baby is preterm, you may need more help. Secondly, is the amniotic fluid clear? If there is meconium, it may obstruct the airway. You may need to prepare to do the suction, or the baby can be more difficult to ventilate. Thirdly, any significant antenatal history. Are there any risk factors like preeclampsia, maternal diabetes, or is the mother having fever? So knowing this kind of history can definitely help you predict how sick the baby can be. And the 4th question is a new one. What is the umbilical cord management plan? And now the NRP put more emphasis on the delayed cord clamping. It has the advantage of improving the hematocrit level of the babies. So ask the midwives, are we delaying cord clamping and for how long? What is our practice for this baby? Do ask them. So now the textbook of the NRP lists those 4, but from my personal experience, there are 2 more questions that you can ask. You may ask them, how many babies are we expecting? Are they twins or just a single baby? It may sound stupid, but in the emergency C-sections or rapid deliveries, communication can really get messy. So you do not want to be standing there with only one warmer and when 2 babies comes out. So always ask this stupid question. And another question I suggest you to ask is any recent estimated body weight from the ultrasound. Knowing the weight prepares you for the equipment size and the medication dose. If they don't have a recent ultrasound or the delivery is quite urgent, use this rule of thumb to mentally prepare. So for babies at around 28 weeks of gestation, you expect they are around 1 kilo. Okay. For those with gestation with 32 weeks, you expect them to have around 2 kilo. For those having 37 weeks, you expect they have around 3 kilo. So you can prepare the equipment based on this. And finally, the most important tip of all, you don't trust your brain to do the math during a crisis. After you receive the call, I would use a piece of paper and write this down before the baby arrives. First, the gestational age, the estimated body weight, and then what is the ETT tube size if we need to intubate the baby, and what is the depth insertion of the ETT, and what is the adrenaline dose and the normal saline dose just in case if we need the CPR or the fluid boluses. You write down all of this and then stick the paper to the warmer so that everyone knows and you don't need to do the math when you are doing the resuscitation. Trust me, it's very helpful. welcome to chapter 2. We call this the golden minute. From the moment the baby is born, you have exactly 60 seconds to complete the initial steps, re-evaluate, and begin ventilation if necessary. Why 60 seconds? Because delaying ventilation beyond the first minute can increase the risk of the mortality. So let's break down the algorithm into 3 simple blocks after the baby is born. Okay, so block 1, rapid evaluation. As soon as the baby is born, ask yourself 3 questions. First question is, does the baby look term? Secondly, is the baby crying or breathing? So you remember the baby's ventilation is the most important thing, right? If the baby cry, most of the time they're okay. But if the baby does not cry, be careful. The third question is, does the baby have good muscle tone? Do they flex their extremities or even moving? So if the answer is yes to all 3 questions, the baby looks term, they're breathing, and they have good muscle tone, the baby stay with the mother, okay, for skin to skin care. And then you can do the delay cord clamping for at least 60 seconds. So this is the latest recommendation from the NRP. You can do the delay cord clamping for at least 60 seconds. What if your answer is no to any of these questions? The baby does not look term, or the baby is not crying, the baby does not have good muscle tone. Traditionally, we said cut the cord immediately and then go to the radiant Roma. Okay, this is always right, but here's a tricky part. In the latest NRP guideline, we have to talk about the umbilical cord. So they specifically mention that there is insufficient evidence to make the definitive recommendation for the next step if the baby is not vigorous. It may still be reasonable to delay the clamping briefly while the obstetric provider gently stimulates the baby to breathe. Okay, so because the guideline on the cord management for non-vigorous babies are not definitive, this decision happened before the birth. Okay, you can say that if the baby is not vigorous, we go to the radiant Roma directly. Or you can agree that it is still reasonable to delay the clamping briefly and then allow the obstetric provider to stimulate the baby a little bit, and then you go to a radiant Roma. But then they specifically mention that this delay cord clamping should not delay your resuscitation if the baby do not breathe or their condition is not good. And just to remind you, you cannot delay cord clamping if the placental circulation is not intact. If there is placental eruption, bleeding period, or cord prolapse, you must clamp and cut the cord immediately to save the baby. And you may also have heard of a term called cord milking. So it basically means you push the blood from the placenta towards the baby using your hand. So if you need to cut the cord quickly, for example, if the baby shape is really not good, but you still want to give the blood volume, you may consider to milk the cord. But I need to remind you that this only can be done if the baby is greater than 28 weeks of gestation. Okay? If the baby is less than 28 weeks, you should not milk the cord. It will increase the risk of severe intraventricular hemorrhage. Okay. So we finished the block 1. If the baby cries, go to mother. If the baby not cry, either go to radiant Roma or delay cord clamping just briefly. So we go to block 2, the initial steps. Once the cord is cut and the baby is moved to the warmer, we have 5 initial steps, and it should be done quickly. First step, warmth. You place the baby under the preheat radiant Roma. For most baby, after you put that on the warmer, you proceed to dry. Okay, but for babies less than 32 weeks, you immediately put the wet baby into a polyethylene plastic bag. Okay, this can create a greenhouse effect to prevent hypothermia. Second step, you dry the baby. Dry them immediately. The wet skin can increase the heat loss, which can cool the baby rapidly. And you should dry the body and remove the wet lining so they are not lying on a cold surface. But if the baby is less than 32 weeks, they just stay in the plastic bag. Okay, you do not need to dry them. Then you position the head and the neck to open the airway, and we call this sniffing position. This means the neck is neutral or slightly extended. And be careful not to hyperextend or hyperflex the neck so much, or you will close the airway. Then clear the secretion. So now a critical change from the old days is now you do not perform routine suctioning. Okay, In the old days, we just put in a suction catheter and then to do the suction. But now more and more evidence shows that aggressive suctioning can stimulate the vagal nerve, which can cause the heart rate to drop, leading to bradycardia, or the baby stop breathing. And so you should only do the suction if the airway is obstructed. Or if you must do the suction, try to use the bulb syringe first. And if there are corpus secretion, you can simply turn the baby's head to one side and to let the fluid drain out naturally. Last step is stimulation. So if the baby is not breathing adequately, you can provide gentle stimulation by briefly rubbing their back, the trunk, or the extremities, but never shake the baby. Block free the decision. Now, after you do the initial step, you warm the baby, stimulate the baby, position the baby. Now what you need to do is stop, look, and listen. Two things. Look at the baby. If they are breathing or they are gasping, okay? Secondly, auscultate. You put your stethoscope to listen to the heart rate. Is the heart rate below 100 beats per minute? So you may count the heartbeat for 6 seconds and times 10, then that will be your heart rate. So if the baby is breathing and the heart rate is greater than 100 beats per minute, we don't stop here. Look at the baby. If the baby have respiratory distress like insucking, we can give them the CPAP. Okay, these will help the lung open, and you can simply set the PEP, the PIP, to 5 cm water, and use the neopuff, hold the mask against the baby's face. But if they are not having respiratory distress, do check the SpO2. If the SpO2 does not meet the target, we may give the free flow O2 to the baby. But the worst scenario will be the baby is not breathing, or the heart rate is below 100, then here's come the most important part. Restart the positive pressure ventilation, PPV, immediately. Alright, we are about to enter the most critical part of the algorithm, positive pressure ventilation. But before we do, I want to give you something to help you on your actual shifts. Okay, I know how hard it is to remember the drug dose and the milestone when you are tired, so I'll create 2 free guides for you, the essential formulas in pediatrics and a developmental milestone cheat sheet. They're completely free. Just click the link in the description below and I'll send them to your inbox. Print them out, put them in your pocket, and to save your brain power for the patient. Okay, let's get back to the baby. The heart rate is under 100 and the baby is not breathing. We are now going to give the PPV. You will usually have one of 2 devices. On the left is a T-piece resuscitator, often called a neopuff. Personally, I prefer to use this, especially for those preterm baby or for those I expect them to be ill, because it can deliver consistent pressure every time. It has less risk of causing pneumothorax. And also, I can set the PEP, PEP, to give the CPAP if the baby is having respiratory distress. In order to give the PPV, you just cover the hole here to give a breath and then let go to exhale. So on the right is a self-inflating bag. If you squeeze to give a breath, but the disadvantage is that it cannot give the CPAP and cannot set the pressure. So this is usually as a backup, or if you think the baby is term, not much risk, you can consider to use this in the beginning as well. So whichever device you use, the goal is the same. We try to ventilate the baby. Okay. If you use the neopuff, set the pressure to 25/5, and the rate is around 30 to 60 breaths per minute. So the rhythm in your head should be breath 2, 3, breath 2, 3, breath 2, 3, breath 2, 3. So it's around 30 to 60 breaths per minute. After you start the PPV, you can do this for around 15 seconds. Then you check the heart rate again. Is it going up? If the heart rate is not going up and the chest is not moving, you do not need the drugs. What you need to do is to fix your ventilation. It means the air cannot go into baby's lung. So how can we fix that? We use the mnemonics MRSOPA. So it's a mnemonics. You do not need to follow the exact order of what I said. Just do the step you think is most helpful first. MRSOPA, M stand for mask adjustment. You adjust the mask or you check if the mask size fits the baby. R, reposition the head. Sniffing position, whether you are hyperextending or hyperflexing the head. S, suction the mouth and the nose. You can use the bulb syringe. open the baby's mouth so that more air can go into the lung. P, I would say this is quite an important step. Increase the pressure. So if you're using the Neopuff, each time you can increase the pressure by 5 cm water. A, alternative airway. After you back the baby, still not working, the heart rate is not going up, or the chest is not moving, you will consider to intubate the baby. Okay? If the airway is really difficult, you cannot intubate the baby, you can use the laryngeal mask. Do not move past this step until you have the chest movement. Always look at the baby if they have chest movement. If they do not have chest movement, you stick with the MRSOPA step, do it again until they have chest movement. Remember, ventilation saves the baby. This is the most important thing. Chapter 4, chest compression. After you do the PPV and MRSOPA, the chest is moving and the heart rate is still less than 60 beats per minute. You should start the chest compression. But I need to emphasize one point. Only perform chest compression when there is chest movement. So make sure you have established ventilation that effectively inflates the lung first. If the lung are not filling, compressions should not help. Do the previous MRSOPA step first. In most cases, effective ventilation alone can already fix most of the problem. But let's say if you're sure the baby is having chest movement, the heart rate is still less than 60 beats per minute, then you should start the chest compression. So step 1, call for help. You cannot do this alone, you need a team. Step 2, intubate the baby if you have not to increase the oxygen all the way. We are moving to 100% FiO2. Step 3, if you haven't already done it, try to attach a cardiac monitor. Sometimes the baby can have PEA, and we need the electrical signal. Step 4, one person should do the chest compression and another person should ventilate. So how you do the chest compression, the thumbs on the lower third of the sternum, and the rhythm should be 1 and 2 and 3 and breath. 1 and 2 and 3 and breath. So 1 and 2 and 3, you compress on 1, 2, 3. And during the end, you release the pressure to let the heart fill. 1 and 2 and 3. And breath is the airway person to squeeze the back. Okay, so 1 and 2 and 3 and breath. The rhythm is like that. All right, so we do it for 60 seconds and then we check it again. If the heart rate is greater than 60 beats per minute now, you can discontinue compression but keep ventilating until the baby breathes on its own. If the heart rate is still less than 60 beats per minute, we will need the adrenaline. Our preferred route is central. It's either using the UVC, umbilical vein catheter, or the IO, intraosseous. It will get to the heart fastest. So the dose for IV or IO, the adrenaline concentration is 1 to 10,000. The dose is 0.2 ml per kilo. So you push it rapid and then flush with normal saline and push it into the circulation. You can repeat it every 3 to 5 minutes if the heart rate stays below 60. But sometimes it can be quite difficult to get aligned, especially in those emergency conditions. If you cannot do the umbilical vein catheter or you cannot do the IO yet, you give the adrenaline through the ET tube. But you will need a much higher dose, which is 1 ml per kilo with the concentration of 1 to 10,000. I need to remind you that if the baby still needs the adrenaline, once you got the UVC or the IO, you should give the adrenaline through the central route immediately. Chapter 5, Hypovolemia or pneumothorax. If the heart rate is still less than 60 beats per minute, despite the chest is moving, CPR, and adrenaline, do think of 2 causes. First, hypovolemia. Did the baby lose any blood? For example, like placental eruption, cord prolapse? The baby can look pale. In this kind of cases, you can give a fluid bolus through the UVC. It's either normal saline, or if you think the baby has bleeding, you can give the O negative blood. Second cause is pneumothorax. During the PPV and we are giving high pressure, this can lead to pneumothorax in newborn because their lung is quite fragile. So if the breath sound are unequal or you can see that the chest is not moving symmetrically, you can do the transillumination through the cold light. So in these kind of cases, you may need to do needle decompression of the chest immediately. Chapter 6, Debriefing. So here is the most important lesson of Chapter 6. Resuscitations are traumatic, not just for the family, but for you, the doctor, or the nurses. We often walk away shaking, replaying every second on our brain and wondering if we were not fast enough or smart enough. And this is why you must debrief. During the debriefing, it's not just about checking the box on the form, but also to protect your heart. So gather your team, ask what went well, what can we do better, but more importantly, is everyone okay? I know the learning curve in pediatrics feels steep right now. Sometimes it feels really difficult. But remember, you're capable. And most importantly, you're not alone. So do it step by step, give yourself some time to improve. Experience will make you grow. And you can only gain experience by time. You can do it. I'll see you in the next video.